Assalamu alaikum. My name is Dr. Usman and I will be discussing the topic prostate carcinoma, role of multiparametric MRI and PIRADS in detection and localization of prostate cancer. We all know that multiparametric MRI is the most sensitive and specific imaging technique for localization of prostate cancer. First of all, what is PIRADS? PIRADS stands for Prostate Imaging Reporting and Data System. It is a system which is used to, it is a structured reporting scheme for evaluation of prostate, for prostate cancer. It is based on multiparametric MRI and it is designed to be used in pre-therapy patients. What is PIRADS Z 2.1? Actually, PIRADS had three versions. In 2012, PIRADS V1 was released for the initial identification of prostate cancer. It was later modified in 2019 by a steering committee with the joint effort of American College of Radiology, European Society of Urogenital Radiology, and Admitech Foundation. This is the history of the PIRADS. As I have already told, in 2012, European Society of Urogenital Radiology drafted guidelines including a scoring system for prostate MRI known as PIRADS version 1, and it was published in 2012. Later, it was modified for making it globally more acceptable by the joint efforts of American College of Radiology, European Society of Urogenital Radiology, and Admitech Foundation. But as soon as it was released, it was found out that there was the inter-observer agreement was good to moderate. Specific assessment criteria were identified that required further clarification and adjustment. Moreover, there was some technical issues associated with the acquisition of multiparametric MRI. So it was again modified and again published in 2019 as PIRADS V 2.1. What are the overall objectives of the PIRADS? The main objective of the PIRADS is to improve the outcome of the patients in the prostate cancer. It improves detection, localization, characterization, and risk stratification in the patient with suspected cancer in the treatment prostate nerve gland. Establishment of minimal acceptable technical parameter for prostate multiparametric MRI. Simplify and standardize the terminology and content of radiology reports. Facilitate the use of MRI data for the targeted biopsy. Develop assessment categories that summarize the level of suspicion or risk and can be used to select for the biopsy and management of the patient. This means that it will be used to identify the clinical significant prostate cancer. Enable the data collection and outcome monitoring of the patients, educate radiologists, and reduce variability in the imaging reporting of the radiologists. Enhance interdisciplinary communication with referring clinicians.
Now, just a minute. It might arise in your mind that why we are discussing such a such a topic here. The reason is the standardized protocol all over the world is to have a patient with increased PSA or a clinical examination which impresses upon you that this patient might be having cancer of prostate. Now, the first thing is not biopsy. The first thing is imaging, and that imaging should have multiparametric MRI. Now, short of having such a thing in our setup, there is no center in this country at least where multiparametric MRI is being done. Now, what kind of MRI that we have, do we really just bank upon us to believe in those reports? It is something of, again, a debate. The second thing is, as I have said earlier on, the first thing is to do multiparametric MRI rather than to go for biopsy. Now, if that multiparametric MRI is not up to a certain level of suspicion on a scoring scale, then a patient with a positive disease may be missed. So, in order to increase the yield of prostate biopsy, we got to have something called standardization in reporting of multiparametric MRI. That is at least what my understanding is. Now, once the score is on a level then the patient is subjected to something which is invasive. Now you see, all over the world this is something of importance, and that is human rights. Nobody has got the right to put the finger in or to put the needle in unless and until it has been given consent by the patient, as well as a consent which is scientific, meaning to say science has to be clear in giving the doctor something of a philosophy that you must progress from one step to the other. So in order to say to your patient that I must see your prostate whether it is malignant or benign is something of no value unless and until you put something with your statement in terms of, for instance, statistics or scoring system, as this PIRAD system is actually proposing. So you see, you have to be very objective in advocating your science, which you understand, and in convincing your patients who by and large in our setup are not that much educated, but they have got the right. So you have to be consider your position as a very important person, because you are actually guiding not only the patient but also you are guiding and leading the whole society. So if you are an educated person, you must be able to have a double sort of responsibility upon you. You can twist your scientific facts, you can twist your knowledge or your skills, but on the same path you can be very sincere about what you understand and what you want to say to your patient, that these are the things. If they agree to it, and there is a score which is like a PIRAD score, if they agree to it, then we want to biopsy your prostate. So this is the kind of background that we should have. Amit is here. Amit, would you like to say something about MRI first and multiparametric MRI later, if you want to come to the podium?
Yes.
I'm very thankful to Dr. Amit. He has been kind enough to come early in the morning to give us something of a background, what actually the MRI is and what is the difference between a normal MRI and a multiparametric or a biparametric MRI.
Good morning, everyone. In fact, I am very thankful to Sir Dr. Asad Saab for inviting radiology to have in collaboration General Club with you people. And I am also thankful to Dr. Osman, who has discussed with me the PIRAD system in the radiology department. Regarding the MRI basic sequences and the difference with the multi-parametric MRI. Normally we used to do the basic sequences are T1 weighted images, T2 weighted images. These are the basic sequences of the MRI. Now something have been added to compile it in the multi-parametric MRI are certain sequences. Say for example, we have diffusion weighted images, and with the progression over time they have also first we used to do contrast sequence in our department also, but with progression of time they have implemented the dynamic contrast enhancement. Now most of us, or in fact all of us, are aware of when we prescribe the CT scan with contrast, we used to do the arterial phase, photovenous phase, delayed phases. Similarly, dynamic contrast enhanced imaging also have some sequences. Like initially we used to do arterial phase, then the enhancement phase, and then the washout phase. So with the progression of time, multiple sequences has been added in order to increase the sensitivity and specificity to detect even the suspected prostate cancers. So certain sequences again have been added, like the diffusion tensor imaging, which has been currently added. Similarly, spectroscopic imaging has been added. I want to show you one or two slides so that we will be more aware and clear of these things. इसको ओपन करें. Yes, बस please. Thank you. And another thing which I totally agreed with Sir Dr. Saab, that the reporting should be standardized. You all know that we have BI-RATES system in breast imaging. Similarly, we have PI-RATES in the prostatic imaging. If all of the radiologists do on the standard protocols, then there will be no mismatch from one person to another. This is what rest of the world is also doing. There is a standardized method. It will not only benefit the radiology, urology, but most importantly, and which is needed, it's most beneficial for the patient as well. So these are the basic sequences I want to show. This is the T2 weighted image. Here we can appreciate this is a prostate, this is a peripheral zone, this is T2 weighted sequence. Normally it appears hyperintense, and this is a central gland. And as you all know that bulk is of the peripheral zone in the prostate, occupying almost 70% of the volume. This is T2 weighted sequence, this is T1 weighted sequence. Here we are unable to differentiate the central and the peripheral zone. So, and if we will give a contrast, it will, if it is diffusely enhancing, normal prostate gland will enhance. But if we have certain lesion, it will enhance more, sometime less than the normal native gland. Okay. Now with advancement of time, now here you can see this was done with surface coil. This is done with endorectal coil. Here we can appreciate more demarcation between the central and the peripheral zone, more clear visualization of the peripheral zone with the advancement of the endorectal coil. This is and here we can see this is one of the article published in the urology journal. I am just highlighting one or two lines here. Here you can see what they have done. They have added magnetic resonance spectroscopy imaging, DCE dynamic contrast image, diffusion tensor imaging. So with advance and with the progression of time, multiple other sequences has been added. We can say supplementary images also in order to increase the detection of the prostate cancer. So anything more about you want to?
Yes, I want to add one thing here. You see, it might come into the mind of any urologist, any resident, or even a senior person that when we talk about the zonal anatomy of the prostate, it is basically based on embryological origin of that portion of the prostate. For instance, peripheral zone originates differently from the transitional zone. Again, central zone is a different zone. It has got also a different kind of histology, and it has also got a different kind of image. It can be picked up very easily, the zonal anatomy, by the MRI. So as Amit was saying about the different weighted images, you can also have an interface between one zone and the other zone, and that interface is very important, as we were discussing 2 days back. Because, for instance, we all know 80% of cancers arise from the peripheral zone. Now, if there is a distortion of the interface between the transitional zone and peripheral zone, it doesn't mean that the cancer is arising from the transitional zone. It is actually arising from the peripheral zone going into the transitional zone. Same thing happens. There is no cancer which arises from the central zone, adenocarcinoma, prostate I'm talking about. But if there is a distortion or there is an increment in the configuration or geometry of central zone on this kind of a figure, MRI figure, then it is actually the transitional, it is actually the peripheral zone going into somehow into the central zone coming into it. So you see, you have to be very much in line with what's happening in terms of reporting of MRI if you want to practice purely something called prostatic cancer management. It is not sufficient to say that I can do radical prostatectomy. Yes, you can do radical prostatectomy. That is something of very much importance, But again, you have to know where the cancer is. Otherwise, you won't be able to judge whether this patient, your patient, needs something called nerve sparing surgery or something called non-nerve sparing surgery. You can't leave behind oncological focus just for the reason that you don't want to have impotency, erectile dysfunction, or incontinence. That is not the case. You have to buy something of a value. You shouldn't buy anything of no value. So you have to be very much precise, and that is the kind of precision that the world is moving in. Now another point, and then we'll move on. Why we need scoring systems? Why there is an analogy between breast cancer and prostate cancer? Why there is a scoring system in radiology of or radiological reporting of a breast cancer and prostate cancer? Because these are two devastating cancers. In urology, number one cancer all over the world is prostate cancer. In female oncology, it is breast cancer. Now, when you have got a scoring system, when you have got a standardization of reporting, we are all moving, like it or not, from augmented reality to virtual reality. So these scoring systems will, again, like it or not, it will be taken over by something called artificial intelligence. A computer and a computer eye will give you more information and a precise information as regards tumor staging as compared to human eye. Now a radiologist or for instance histopathologist always reports what his eye or her eye is actually seeing. So it is basically a pattern recognition. So there are many patterns at the back of my mind, and I see that this is the kind of pattern, a cribriform pattern, and I call it cancer of prostate. The same thing happens with a computer generated report, because the eye of the computer has got a knowledge or reference bank of millions and millions of that kind of tissue image. So what it matches is not hundreds or thousands, it matches with millions of patterns. So the pattern recognition and the recognition of something which is a rare thing is better with a computer rather than with a human eye. Maybe I'm too difficult to understand, but this is something which you all have to understand one point in time in your life in near future, because many of the things will be taken over by something called artificial intelligence. And then if you are not in pace with what's happening around you, you will be lost. You will be lost in a maze of what's happening around you, who is reporting. Can I report a chest x-ray because there is a pneumothorax? A computer can generate a better report, because again, what you see on a chest x-ray is actually a pattern, and what you prescribe is something from the back of your mind that this pattern matches that pattern, so this is pneumothorax. There are many subtle differences between many shades of gray. It's a shade of gray which you call pneumothorax or pyothorax or hydrothorax. It's nothing. Life is just black and white, and other things are we have added into it. This is philosophical. So thank you very much.
One more slide,
Yes.
sir, if you permit
Yes,
me.
yes.
Sir has beautifully extended about when we should decide about the radical prostatectomy, how we can specifically locate it to the particular area of the gland in order to detect that cancer. One slide I want to show you. Now, this is an example of multi-parametric. Here you can see these are the T2 weighted images which has localized a lesion. Now, diffusion weighted imaging have been added. So it particularly localize and differentiate from rest of the gland that it is showing restriction, which is concomitantly showing low signals, or it becomes black in general language, I should say becomes black, and particularly specify a lesion. And further dynamic contrast imaging has been added. In the initial phases you can see the enhancement and here the washout. So again we have it has been proved that the lesion is particularly located. It is not only located at a particular site of the gland, but it is showing enhancement and washout, which is later MRS has been added, which show a type 3 plateau curve. Here you show uptake and here you show dropout. So by adding one sequence to another, the detection rate, the sensitivity, the specificity has been increased. It will not only save the rest of the prostate. I don't know more about the surgery, but we can specify excise the particular location. So this is what the beauty of the multiparametric MRI is.
Right, thank you.
Thank you, sir.
Then there are certain limitations of the PIRADS. PIRADS is not a comprehensive prostate cancer diagnosis document, and it should be used in conjugation with other current resources. Moreover, it does not give us any information about the recurrent prostate cancer, progression of the disease during surveillance, MRI evaluation of other part of the body, for example, skeletal system, in which the prostate cancer usually spread. Now, this is a diagram how we can use the multiparametric MRI in association with various tumor markers. First of all, we will do the PSA of the patient. If the PSA is less than 1, then it is normal, and we will follow the patient again with the tumor markers. However, if the results are abnormal, then we will perform MRI of the patient. In MRI, if the MRI is normal, then we will follow the patient again for after 5 to 10 years with the tumor markers. If it is equivocal, then we will repeat the MRI after 6 to 12 months. If the MRI is abnormal, then we will consider the patient for MRI targeted biopsies, with or without systematic biopsy. Then there are certain clinical considerations. Timing of the MRI. Whenever we perform prostate biopsy, there is a risk of hemorrhage. Hemorrhage after prostate biopsy can present as a hyperintense lesion on T2 weighted images, which can affect multiparametric MRI assessment and grading. So at least 6 to 8 weeks interval should be taken post biopsy for multiparametric MRI. Moreover, there is preparation for the patient before the procedure. Antispasmodic agents are used to decrease the bowel peristalsis. Minimal preparation enema administered to the patient in the hours prior to the exam may be beneficial. Patient should be in prone position, or suction should be used to remove the air and decompress the rectum. Then there are certain checklists which are used before the multiparametric MRI. Here we take these are the checklist which is used by the technicians there. Here we have what is the indication of the MRI, what is the PSA of the patient, biopsy date, what are the findings of the truss. Moreover, lesion characteristic, diameter, its location, T2 and diffusion weighted images characteristic, sign of any extra prostatic growth. Then conclusions.
It might arise in your mind that why biopsy is put in here, because this is something which is done prior to biopsy rather than after biopsy. Now, you might have patients who come to you after a history of going through biopsy. So if there is a history of biopsy, then you must consider something which is like post-biopsy hemorrhage or artifacts which are related to needle insertion. So if there are any, and if there is a history, then you always consider this fact before giving your statement about PIRAD classification.
Technical specification. Multiparametric MRI, as I have already told, consists of T2 weighted images, diffusion weighted images, and dynamic contrast images. Prostate MRI acquisition protocol should always be tailored to specific patient, clinical questions, management options, and MRI equipment. At least one pulse sequence should be used a field of view that permit evaluation of pelvic lymph nodes to the level of aortic bifurcation. 1.5 Tesla magnets are used and they are good, but 3T is the best. The recommendation focus only on 3T and 1.5T MRI scanners. Prostate multiparametric MRI at lower magnetic field strength, that is less than 1.5 Tesla, is not recommended. Endorectal coil may be particularly valuable for high spatial resolution imaging used in cancer staging and for inherently low sound to noise ratio sequences such as diffusion weighted images and high temporal resolution on dynamic contrast enhancement. Credible satisfactory results have been obtained at both 1.5 Tesla and 3 Tesla without the use of endorectal coil. Fluid inflated endorectal coils have better imaging quality as compared to air inflated images, but are not 100% artifacts free. Then the anatomy. As you all know, from superior to inferior, the prostate gland consists of base just below the urinary bladder, the mid gland, and the apex. It is divided into 4 histological zones: the anterior fibromuscular stroma, which contains no glandular tissue; the transitional zone surrounding the urethra, proximal to the veromontana. It contains 5% of the glandular tissue; the central zone surrounding the ejaculatory duct contains about 20% of the glandular tissue. On MRI, it is difficult to differentiate central gland from the transitional zone, and they both are labeled as central zone. The outer peripheral zone contains 7 to 80% of the glandular tissue, and most of the adenocarcinoma arises from there. When BPH hyperplasia develops, the transitional zone will slowly increase in percentage of the gland volume. This is the picture. This shows the sector anatomy of the prostate cancer. Previously, in Pirate Z2 version, there were 39 total sectors, but they are increased in Pirate V2.1, and now there are 41 versions, 38 for the prostate, 2 for the seminal vesicle, and 1 for the external urethral sphincter. Peripheral zone at prostate base, midgland, and apex are each subdivided into 3 sections: anterior, medial posterior, and lateral posterior.
Just one point here, go back to this slide. Amit, since you are here and I have also included your seniors in this discussion, I've been in discussion with them for the past 2 weeks at least to just standardize something called transrectal ultrasound guided biopsy. Whether we go through the transrectal route or we go through the transperineal route, we got to have an kind of a map, and this is the kind of map that this presentation is giving. Now, if you follow this kind of a map during your, because you are also one of them who do these biopsies, so if you follow this, then it will be easier for you to again standardize your MRI report, and then you can always fuse that image with this kind of guidance, and then your needle will actually be in a sector. Now, if for instance, if we take one sector, and that is anterior fibromuscular area, it is quite wide. You can't have one biopsy from this sector, either right side or left side, representing the whole sector. You got to have, if there is a suspicion of maybe hyperechogenicity or hypoechogenicity, so something different from isoechogenic, then you can have 2 or 3 different needle points within the same, maybe right or left anterior septal, anterior fibromuscular area. The same goes with any other sector. So if you do biopsy in sectors, you will be able to map the prostate properly at 3 different levels: the upper level, that is the base, the apex, and the mid level. And then it will not be something of random selection. It would be again targeted. So whether you do it as a fusion technique, taking multiparametric MRI to guide you, or you can take the same transrectal ultrasound probe guiding but taking samples like this. So it will, I think, we will be able to move one step forward But again, it has to be something coming out from your side, radiologists, rather than from us. We have got this kind of a wish list. Of the practical implications, whether it has to be, it can be done or not, should come from your side. So there has to be a discussion between us and you.
Yes, sir, I totally agree. Again, the areas of the biopsy or sectors of the prostate we used to choose should be standardized. Else anybody is doing from the radiology side. And yes, sir, this needs to be discussed among the...
Because if you just mark your needle that you have taken from this point, and this is the base, and this is the anterior segment, and this information is given to histopathologist, who is the third partner in our team. Now, histopathologist will always see that specimen in greater details, maybe applying some reagents, different kind of reagents, maybe immunohistochemistry. That would give us more information. If it is closer to the periphery, again it is an information to the surgeon, whether to spare the nerves or not. So every information which is given by you people will be of a lot of benefit to two other persons. One is the histopathologist, the other one is us, the urologist. So again, it's a teamwork. We can't do it in solitary fashion. We all have to work together. So this is my wish as well as my desire that radiologists should take the lead. We can always be there to just discuss, because this is something which we primarily take up, because the patient comes to us for the very first time, and we are the one who says goodbye to the patient. You two are very important. Unless and until histopathologists and radiologists work together, we will not be able to achieve something of a standard or standardized procedure like radical prostatectomy.
Yes, sir. Yes, sir, I agree with this. Right.
Now this is the T2 weighted images. Here we can see that the peripheral zone is hyperintense, whereas the central zone is hypointense. This is another view. Here we can see that this hyperintense area is the peripheral zone, and hypointense in the middle is the transitional zone. Now the use of sector anatomy. With the help of this sector anatomy of the prostate gland, division of the prostate and associated structure into the sectors standardize the reporting and facilitates the precise localization for MRI targeted biopsy and therapy, pathological correlation and research. Moreover, since the relationship between the tumor contours, glandular surface of the prostate and adjacent structures such as neurovascular bundles and external urethral sphincter and bladder neck are valuable information for periprostatic tissue sparing surgery, the sector map may also provide useful roadmap for surgical dissection at the time of radical prostatectomy. Pyrites assessment. The score is assessed on prostate MRI images, T2 weighted images, dynamic contrast and diffusion weighted images. If dynamic contrast or diffusion weighted images are insufficient for interpretation, the newest guidelines recommend omitting them in the scoring system. Currently, MR spectroscopy is not included in Pyrite scoring. A score is given according to each variable. The scale is divided on a score.
I'm interrupting you. This varies from one article or one research to another, right? Currently, they are saying MR spectroscopy is not included in the Pyrite scoring. Maybe they have not included in their study this MR spectroscopy and they just write down it as it is not included. What I have seen after discussing with you or previously in my knowledge, MR spectroscopy is now necessarily included. MR spectroscopy basically it detects the metabolites we used to do in the brain imaging. Say for example, if there is a lesion in the brain, sometime the lesion is ring enhancing. We can't label it as always an abscess because it is ring enhancing. It can be ring enhancing neoplastic lesion as well. Then we have a sequence called diffusion restriction, DWI. Sometime both can show diffusion restriction. Then how we will prove that this is neoplastic or infection? Then we have magnetic resonance spectroscopy. It's a sequence which detects the metabolites. Like neoplastic lesions would have a choline peak. They will peak because they have much of the choline inside them. Infection or abscess would have lipid lactate peak. So now current recommendations, even there is an article published recently in 2016 in your Egyptian Journal of Radiology, they have included, and I have already shown a sequence of that in that. So this varies. I want to clear you people that this varies from one research to another. Now day by day, currently they have included diffusion tensor imaging. In a year or back, this was only used to supposed to do in the brain imaging. Now they have included diffusion tensor imaging in the prostate as well. So this varies, Dr. Usman, from one research or article to another article. Okay.
Okay.
Can you explain spectroscopy in 2 minutes? MR spectroscopy. What is the difference between MRI and spectroscopy?
MRI is MR spectroscopy is a part of the sequence of the MRI, multiplanar MRI. This spectroscopy basically only detects the metabolites, what the metabolite particular lesion has. If it is an infection, inflammation, it's an old infarction, it's a neoplastic, it's a benign, it's a malignant, it will detect. So it will ultimately increase the sensitivity as well as the specificity of that particular pathology we have on routine sequences of the MRI.
You see, it's the same thing. For instance, if you have got a CT scan and if you want to see whether there is some metabolic activity going on and whether this lesion is metabolically active or not, you combine PET with CT, right? The same thing is happening here. You use the same kind of reagent, and that is choline, in MR spectroscopy. Now this is an MRI to the level of angstroms. Angstrom means 10 to the power minus 9, which means that you are actually seeing something at the cellular level. So that has been going on for quite some time, and very soon, maybe 5 years down the line, we'll be having nothing called histopathology. It will all be taken up by MRI, and that is known as functional MRI. So MRI has got a lot of implications in very near future. So and this is what is written here, and what Usman is telling is one version of PIRAD system. So there are many versions, and it always happens that one version is taken up by another version, and there is an improvement. So maybe in the next version, spectroscopy, MR spectroscopy will be part of the protocol.
So spectroscopy is a part of multiparametric MRI, not the normal MRI.
Yes, it's not the part of the normal MRI.
Right.
So as I have told, multiparametric MRI consists of diffusion T2 images, diffusion weighted images, and dynamic contrast. A score is given according to each variable. The scale is based on a score from 1 to 5, with 1 being most probably benign and 5 being highly suspicious of malignancy. There are 5 classes of PIRADs, PIRADs 1 and 2 with very low risk, or PIRADs 1 with very low risk of prostate cancer. 2 also have low risk. PIRAD 3 is intermediate and is usually considered equivocal. PIRAD 4 and 5 has high risk of prostate cancer. Now T2 weighted images. What are the appearance of the lesion on the T2 weighted images? In PIRADs 1, T2 weighted images usually show uniform hyperintense signal intensity. This is only for T2 weighted images for the peripheral zone. Here we can see that this is hyperintense area. No lesion is identified in this area, and it is labeled as PIRAD 1. If there is a linear arrow, as this is here, we can see that linear arrow, wedge shape or diffuse mild hypointensity in the peripheral zone, then it is considered in class 2. Class 3, which is equivocal, there is heterogeneous signal intensity. This is hypointense lesion in the peripheral zone and is considered more likely prostate cancer, and it is associated then with tumor markers and the biopsy of the patient. This is the class 4, circumscribed homogeneous, moderate, hypointense focus mass confined to the prostate gland, and its size is usually less than 1.5 centimeter. If the size is greater than 1.5 centimeter, then it will be considered in the class 5. Then there is T2 weighted images for the transitional zone.
Usman, you conclude your presentation because time is up.
Homogeneous intermediate intensity signal on class 1, circumscribed hypointense or heterogeneous encapsulated nodules in the class 2, and heterogeneous signal intensity and obscure margins in the class 3. And then the lesions again, if there is lenticular lesion in the transitional zone less than 1.5 centimeter, it is class 4, and greater than 1.5 is considered in the class 5. Then there again, the prostate cancer is divided on the diffusion weighted images into 5 classes, and they are, in my view, when the patient has low ADC value and high B values, it will be considered a low ADC value and high B values are associated with prostate cancer. Then dynamic contrast enhancement. It is considered negative if there is no early enhancement or diffusion enhancement and corresponding to the focal finding on T2 or diffusion weighted images, or focal enhancement corresponding to the lesion demonstrating feature of BPH on T2. It is considered positive for focal and earlier than or contemporary with enhancement of adjacent non-prostatic tissue and correspond to the suspicion finding on T2 or diffusion weighted images. These are considered negative. Diffuse enhancement not corresponding to the focal lesion. Here we can see that this is a lesion, but there is a hypointense signal surrounding the hypointense rim around the. It is most likely consistent with the BPH finding. And these are the images which shows that they are positive dynamic contrast enhancement. This is a lesion, it is hypointense and it has high B values, which is seen on the dynamic contrast enhancement. Then on dynamic contrast, again, it is divided into the 5 classes, and each class is numbered accordingly from 1 to 5. Pirate scoring. In Pirate G 2.1, it is considered that diffusion weighted images are significant in peripheral zone, while the T2 weighted images are considered important for the transitional zone. Assessment without adequate diffusion weighted images. If the diffusion weighted images are not available, then T2 and dynamic contrast enhanced are used. If all the cases, if there is class 3 of on the T2 weighted images, then we do dynamic contrast enhancement. If there is no enhancement, then it is considered in the class 3. If there is enhancement is positive, then it is considered in the class 4 of the pyrites. Assessment without adequate dynamic contrast.
Usman, please conclude.
Conclusion. A consistent instruction on how to calculate the overall pirate score is lacking. Since these guidelines were published, several research groups validated the pirate score, and most of them calculated a pirate sum score from 3 to 15 by summation of 3 single scores. In conclusion, pirate classification is still work in progress and will have further improvement in future. Furthermore, studies have to be done to validate the accuracy and inter-observer variability. It is considered that with the development of multiparametric MRI, with the use of MR spectroscopic image, diffusion tensor images, diffusion kurtosis images, multiple B values assessment of fraction, ADC, intravoxel image, and blood oxygen level dependent imaging, the pirate scoring will be modified later and will be released, which will be helpful for the radiologist as well as for the urologist for the detection and localization of prostate cancer. Thank you.
Right, thanks.